Today I'm going to talk about diabetes and heart failure. I want to acknowledge with gratitude that I work on the unceded homelands of the Musqueam, Squamish, and Tsleil-Waututh First Nations. I'm going to talk today about the definition of heart failure, the incidence and link between heart failure and people with diabetes, some of the therapeutic considerations, SGLT2 inhibitors and their role in treating heart failure, and as a nurse, how you would support a patient when they are using SGLT2 inhibitors. Heart failure is a type of heart disease where the heart no longer pumps enough blood to meet the body's needs. Some of these symptoms can include shortness of breath, coughing a lot, they could be tired, they have chest pain, a bit of weight gain, and swelling in the feet, ankles, and legs. So how many of you believe that there's a link between people with diabetes and heart failure? Have a thought about that. There definitely is a link. Diabetes can cause heart failure independent of ischemic heart disease, and that's because it causes diabetic cardiomyopathy. And what's the incidence? It's a 2 to 4-fold increase in heart failure in people with diabetes. Remember though, they could be asymptomatic and have abnormalities of the ventricular systolic and diastolic function. They could also have independent risk factors for heart failure, which are elevated hemoglobin A1C and albuminuria. What's the prevalence? Well, in nearly every clinical trial involving people with heart failure, diabetes was there in over a third of the subjects. So there is an absolute link between diabetes and heart failure. What do we need to consider? So people with diabetes are at an increased risk of developing hyperkalemia and a worsening renal function when they are using RAS blocking agents, ARBs, ACE inhibitors, and direct renin inhibitors. So we need to watch for high potassium that's getting even higher and a declining renal function. SGLT2 inhibitors can decrease the risk of heart failure in patients with type 2 diabetes and decrease the risk of major cardiac events in patients with heart failure and diabetes. So it's a great drug for that. And specific SGLT2 inhibitors, empagliflozin and dapagliflozin, can decrease major cardiac events in patients with heart failure only. So it is being used independent of being treated for diabetes. So how do we treat heart failure in patients with diabetes? The same as you would in a person without diabetes, but they have a couple of extra tools in the toolbox. And that is metformin has been shown to not make it any worse, and probably a slight little increase in a couple of studies in efficacy. So it is recommended for patients who have an eGFR greater than 30 and they have diabetes. If the eGFR is less than 60, you want to use the RAS or valsartan blockade carefully. Do not use TZDs, and those are the Actos and Avandia or pioglitazone, rosiglitazone, as they do have a marker for increasing heart failure, fluid overload as well. And you want to avoid saxagliptin in patients with heart failure and diabetes, and saxagliptin is in that family of linagliptin, sitagliptin. They're a DPP4 inhibitor, and there was an increased marker of heart failure using saxagliptin in studies. SGLT2 inhibitors of empagliflozin and dapagliflozin have data to prove that you can recommend this for patients with or without diabetes to reduce the incidence of heart failure. There is an SGLT2 inhibitor called canagliflozin. They are doing studies very frequently right now to try to see if it's a class effect that the SGLT2 inhibitor class reduces heart failure. So this presentation is current as of June 2022, and I'm sure there'll be new data coming out with including canagliflozin. So what do SGLT2 inhibitors do? In our renal system, we try to hold back about 180 grams of glucose a day in order to use it in our cells. And then what we do is pee out the rest. So SGLT2 proteins are located in the proximal tubules of the renal system, and about 90% of the glucose is reabsorbed through this proximal tubules. So if you put an SGLT2 inhibitor in, it will block the reabsorption of 90% of the glucose, allowing you to pee extra glucose out. Only 10% of the glucose is in the distal tubules, and that's where SGLT1 proteins are located. So really the best bang for your buck is in the SGLT2 proximal tubule area. We have a renal threshold of about 6.9 millimoles per liter, and about 7. So when we get to 7, when our glucose gets to 7, we spill out this extra glucose. So if we block the reabsorption of part of this 180 grams, we're going to pee extra glucose out. Someone with type 2 diabetes could have a renal threshold of 14 or 15, which means it's allowing the glucose to get to 14 before it's spilling the extra glucose out. So what these drugs do is lower the renal threshold back down to where everybody else has it, which is about 7. So it's blocking the reabsorption of about 100 grams of glucose. Of that 180 grams, it is preventing 100 grams from going back in. And glucose has calories in it. So you basically are excreting about 400 calories a day because that extra glucose is now not being reabsorbed back into the body. There's a low incidence of hypoglycemia because you're allowing the glucose level to get to 7 before you're going to spill anything out. And because the pancreas doesn't release insulin until carbohydrates are ingested and you're peeing those carbohydrates out, there really is next to 0 level of hypoglycemia. This also results in mild weight loss because you're losing about 400 calories a day. There's a slight blood pressure reduction and a slight rise in HDL. So these are the class. This is SGLT2 inhibitors. The class of drugs includes canagliflozin, dapagliflozin, and empagliflozin, and these are the doses that someone could use. So a landmark study in 2015 resulted in a change of practice. So 7,000 patients with type 2 diabetes were studied for 2.5 years in the EMPA-REG study, which was empagliflozin. The inclusion criteria was an A1C between 7 and 10%, no evidence of severe renal failure, so they had to have an eGFR greater than 30, and their BMI needed to be less than 45. And what they were measuring for a primary outcome was a 3-point MACE. So did they have a major cardiac event, a non-fatal MI, or a stroke? And the secondary outcome was a 4-point MACE, which is all of the above, plus hospitalization. They tested for inferiority first, and then tested for superiority. What the outcomes were remarkable. The weight was decreased, waist circumference was decreased, blood pressure decreased between 3 to 5 millimoles per mercury, both diastolic and systolic. LDL was a little bit raised, so there's a note there, and HDL slightly raised, which is a good thing. The genital infections were increased, and that's because you have extra glucose in the urinary system. So definitely there's issues that you need to deal with there. There was no difference in hypoglycemia, bone fractures, no difference, and A1C was reduced without hypoglycemia. So the overall results were that there was a 14% relative risk reduction using empagliflozin in the 3-point MACE, a 38% reduction in CV death, 35% in heart failure, and 32% reduction in all-cause mortality. And there wasn't a marked increase in hospitalizations, so the 4-point MACE didn't reach statistical significance. But here's the visual of this. So you put someone on empagliflozin, or you put them on a placebo, and you can see from the very beginning there was a divergence in the curve. They had to stop this study early because it was unethical to keep going, knowing that they were giving placebo to patients and the empagliflozin could reduce the risk of 3-point MACE so drastically. And so that resulted in a publication and an announcement to practitioners in Canada to say use SGLT2 inhibitors higher in the line of fire. So use them early. So what patients can use an SGLT2 inhibitor? Type 2, if they have diabetes, and it is contraindicated in type 1 diabetes. The renal impairment, so it won't have an effect on glucose lowering if you don't have enough of an eGFR to lower the glucose, but it will help in heart failure and cardiovascular risk, and also the reduction of albuminuria. And cardiovascular patients with or without type 2 diabetes. So what does it do? It reduces glucose levels, reduces heart failure, slows the progression of kidney disease, particularly albuminuria. It has no risk of hypoglycemia, weight loss, increased HDL, and reduces blood pressure, both systolic and diastolic. So there was another study. When you talk about patients who are acutely ill, you're saying, well, okay, they come in with heart failure. How soon after they've been stabilized can we start them on one of these and see what the results are? So they waited about 2 to 5 days once they were stabilized after coming in with acute heart failure. They either had diabetes or didn't, so it didn't matter. They started them on the SGLT2 and followed them for 9 months. And there was a statistically significant difference at 12 days. So the take-home message from that study is start polytherapy, your ACEs, your ARBs, your ARNs, your SGLT2 inhibitors, beta blockers, spironolactone. Start them quickly and low dose. You are better off on low dose of all of them than waiting and increasing the dose on one before starting another, because every class does a slightly different thing. And you can use an SGLT2 inhibitor in an eGFR greater than 20 for reduction of heart failure. So what are the precautions? Of course, every drug has a precaution, and there are certain ones with SGLT2 inhibitors that maybe a patient is not a good candidate for. So if they are elderly and they have an uncertain oral intake, or they don't monitor their glucose levels and they live alone, this might not be the patient that you're going to suggest this in. If they're on loop diuretics, just note you may have to decrease the dose of loop diuretic because the effect would be potentiated by the SGLT2 inhibitor. Remember, glucose is osmotic. It pulls fluid with it. So a person is going to pee more and be more dehydrated with an SGLT2 inhibitor because that glucose is pulling the fluid with it as it's going out, being urinated out. If they have a previous history of UTIs or yeast infection, you want to counsel them on hydration and hygiene. They need to keep things clean down there, and they will reduce the risk of UTIs and yeast infection. Having moderate chronic kidney disease and taking meds that cause high potassium, like ACE inhibitors, angiotensin receptor blockers, they're at a greater risk for higher potassium levels, definitely with canagliflozin. If they have an elevated LDL, this drug could increase the LDL slightly as well. And as I mentioned, it can cause dehydration and hypotension. But the note here is that if they are normal, if they have normal blood pressures, there's about a 3 to 5 millimeter of mercury drop in the systolic blood pressure. If they are hypotensive, there was only a 1 millimeter per mercury drop. If they have a previous history of bladder cancer, dapagliflozin in particular, or pancreatitis, would not use this drug. And it can cause euglycemic DKA, which is a relatively normal glucose level, and high ketones in people with type 2 diabetes. And I'm going to walk through that very shortly. So what's the nurse's role in educating patients? Because again, there's great things that this drug can do, but there's also things they need to watch for. So drink 1 or 2 extra glasses of sugar-free fluid a day. Water is preferable unless they're on a restriction. And the rationale is that it dilutes the glucose and flushes out through the urine. Monitor for dehydration, and here's some of the symptoms of that. And it just means that your urine output is greater than your oral intake, so you need to take more fluid. You're going to have to pee more. It means the drug works, and that's because that glucose is being flushed out through the urine. Monitor for yeast infections and UTIs, and it means the glucose is building up in the urine, and it can be a host environment for an infection. Stop taking the SGLT2 inhibitor if you're too ill to take fluids. That can prevent euglycemic DKA. And monitor for euglycemic DKA, because they may think that since the glucose level is relatively normal, that the person isn't that ill. So what is it? Euglycemic DKA. It mimics diabetic ketoacidosis. So it's difficulty breathing or fast and deep breathing, unusual fatigue, confusion, rapid weight loss, nausea and vomiting, abdominal pain, excessive thirst, and fruity smelling breath. The presentation could include, and I've seen this, where they come in with a glucose level of 13, but they're very ill. So the glucose levels aren't that high, but they're showing the signs of DKA. And beta hydroxybutirates, or BHBs, are a more specific measure of diabetic ketoacidosis compared to just ketones, because all of us can put ourselves in a ketotic state by just not eating carbohydrates. Think Atkins diet or diets where we have no carbohydrate in a keto diet. Their pH is low, and their bicarb could be low as well. So the DKA triggers are that they could have an illness or a stressful event that increases their risk for this, increased alcohol intake, decreased caloric intake, and decreased levels of insulin that they've taken. But the incidence is only about 0.1% in patients with type 2 diabetes, So I'm sure all of you are familiar with the SADMAN's acronym. This used to be SADMAN in my young days of nursing, and they've added S at the bottom just to include SGLT2 inhibitors. These are the medication classes that you would hold when a patient is not eating, drinking well, and they're ill. So what are the take-home messages? People with diabetes are at a increased risk for developing heart failure. They can be asymptomatic, and metformin and SGLT2 inhibitors are recommended for glycemic control and reducing the risk of heart failure. We need to give patients education when they're taking SGLT2 inhibitors and remind them that if they're ill, they need to stop taking it until they can take fluids again. And SGLT2 inhibitors, empagliflozin and dapagliflozin, can be used in patients without diabetes and have a renal, cardiac, and glucose lowering benefit. Thank you for your time.